Maxine and I had a lot of discussion about what we could say, because there isn't a blueprint for how a clinical nurse service is set up. So maybe some of the experiences that you have are because there are different ways of setting up clinical nurse specialist services throughout the country. So what we wanted to do was to give you an outline of what a clinical nurse specialist is, and in a way it's almost like a person spec, I suppose, about the service provision in Sheffield, because it will be different to what there is in the rest of the country. The general role of a CNS, because NICE and everybody else tells us what a CNS should be. And then Maxine's going to take over and she'll talk about how we in Sheffield support the GIST patients. So, what is a clinical nurse specialist? Now, this isn't Maxine at an earlier time. The reason that we've got this here is that what we wanted to say is that a clinical nurse specialist is an experienced registered nurse. So it's not a job you go straight into once you've qualified. And usually a clinical nurse specialist has to be trained to graduate level. And now as time's gone on, that's been moved up and most of us are moved towards master's level. We are deemed to be clinical experts in evidence-based practice. So what that means is that whatever we do, we have to have the evidence to show that it actually works. So it can't be something that we just think, oh, let's try this is good. We treat and manage the health concerns of patients. Now, the important part of that is it's of patients. So it's what the patients perceive their health concerns to be. And we're going to come back at that and you'll see it comes up several times, and perhaps that is something that the last session in some ways touched upon. How do we know that you're needing some psychological support? And most clinical nurse specialists, all clinical nurse specialists, are focused on particular populations. Now clearly our population is a disease group, but it could be an age. So for example, where we work, there's a CNS who looks after the patients from 16 to 25, and we do work quite closely with her with both sarcoma and GIST patients. It could be that it's focused on specific care, so for example palliative care, and again we work sometimes with our palliative care colleagues. Another area could be a treatment area such as lymphedema. So not everybody is disease based, but clearly we are. So I've got to make sure my assistant keeps up with me. This is about the Sheffield team and how we are set up in Sheffield. So there's 3 of us, which equates to 2.6 whole-time equivalent nurses. And that sounds quite good really. But then we also are responsible for a second cancer site, and for us it's endocrine cancers. And I would have said before that we're really CNSs for rare cancers, because if you looked at that pie chart, endocrine comes in that bit as well. But given what's been said, maybe it's not, we're not as rare as all that. We belong to the surgical directorate, and that's also really important. But from our perspective, that's almost an administrative thing. So if you like, the pot of money that pays us sits in surgery. All our information about the hospital at large, the procedures, the policies, is within the surgical directorate. We have our personal reviews done within the surgical directorate, but we do work outside of it as well, and that's quite unusual. It's very unusual in our trust. Most of the clinical nurse specialist teams who are from the surgical directorate will work just with patients having surgery, but we cross the boundaries and we go into oncology. So we follow our patients from the day that they have their surgery through to oncology and surveillance and monitoring. So there is some continuity of care, and we would hope that that means we get to know our patients really quite well over time. Because of that, we cover 3 hospitals in the group. So although it looks quite nice that there's 3 of us, it can be that we're quite thinly spread really. 2 of the hospitals are acute trusts that do the surgery. And on the site of one of them, there is also the hospital that Prof Well works in, the oncology hospital at Weston Park. But the other hospital is at the other side of Sheffield. And they do a lot of the abdominal surgery, so we go across there to see our patients there. Within Sheffield's service, we would see about 120 new sarcoma patients a year, and about 17 of those would be GIST patients. Now this data came from our multidisciplinary team meetings, so all the patients who have a sarcoma diagnosis come through the sarcoma MDT. Now, it would have been really helpful if I'd put what the population base was. And Sheffield was part of North Trent until quite recently. Now, North Trent's population is about 1.5 million, but we also have some patients that are referred in further than that. We are now part of Yorkshire and Humberside, and it is not really quite so clear where the boundaries are going to lie in the future. So, the key to our role really is the coordination of the patient's pathway through complex investigations and treatment options. And given some of the things that you've been saying, I suspect some patients didn't have a very smooth ride through their treatment, well, from diagnosis to treatment. So everything we do is based on that key element, really. Now, our idea is to try and avoid a sort of faulty towers where there's chaos and miscommunication. So that's why that slide's there, really. So how do we do this? How do we avoid faulty towers? So the first thing is that technical knowledge and about cancer and treatment. Now, we meet our patients, and one of the things that is important is that we have the knowledge to support them when they are first given their diagnosis, so that we have a knowledge of what's going to happen to them, so that we can answer their questions. It's important that we know those patients as individuals, and their pathway could be quite individual. So again, it's about us having the knowledge to give the appropriate support to each patient. Based on patient experience, we're responsible in some ways for changing the treatment. Now, that doesn't mean the treatment that you have for your actual problem. It's a much broader concept than that. It's how, where, the environment, how you're treated, and those sorts of issues. Recently, we've done a questionnaire for patient experience of their from diagnosis onto the wards for their treatment into outpatients, and all those things that is an obvious part of the pathway, with the idea of saying these are our areas that we need to work on, these are the changes that we need to make. Holistic needs assessment. Now, this is going to come up several times, and it's one of the very important things that probably are being emphasised really in a lot of areas now. And the idea is that each patient has a holistic needs assessment that allows us to say, right, okay, what are the things that are important to you? What concerns do you have? And for us to then be able to point you in the right direction for agencies and disciplines. So if we went back to what we've just been talking about, for some people, it isn't at the moment of diagnosis, as Judith was saying, that there's the most anxiety. If something is actually happening, because people are fine while things are happening and they feel things are being done, but sometimes it's at the end of all of that that there's a problem, when it actually stops and think, gosh, somebody told me I had cancer. And it's at that point. So it's being aware and doing those holistic needs assessments at different times. We need to tailor the care that we give to the individual patients and the individual patient's needs. And that's really what holistic needs assessment's about, but it will crop up a few times, I have to say. And really, I think this is one of the most important things. We're an accessible key professional for the multidisciplinary team. So that sounds really quite important, but what we really mean is that we do have a telephone number. We are contacted by the healthcare professionals. We are contacted by patients. So we are a link through, and we are very accessible. So I hope that what came across there was that the patient is at the focus of what we do. So on the first top of this is clinical diagnostic skills. Now, clearly we don't do the diagnosing, but what does happen is that during your pathway you telephone and tell us there's something that's changed. So it's really important that we have the skill to ask the right questions, to refer to the right people, and offer you the right support. Again, assess holistic needs. This is just going to come up quite a few times. It's because what we want to give is individual care, and if we don't do that assessment and we haven't got the skills to ask the questions and do the assessing, we can't help, we can't lead you in the right direction, we can't point you to the right people to help. Communicate and advocate. Now, what we find quite often is that there will be a consultation, and it'll be after that we get a phone call, and it'll be, what did they say? What did they mean by this? Oh, I'm not happy about that. And then we can explain things, we can communicate back to the doctors or whoever the healthcare professional was that saw you, and actually say there's some questions. It could be to make another appointment so that you can go over those issues. It can be that we can answer the questions, or it can be that we just act as that person that goes between and comes back with the answers. I think one of the things that happens when you have a cancer diagnosis is that it's not just about the person who has the diagnosis, it's about the family, and it becomes a family diagnosis. Everybody in the family is affected, and part of what we do is to accept the fact that we need to support family members as well as the patient. We've mentioned that everybody should have a key worker, and I just think this is the absolute crucial issue. What we find is that patients who have quite a difficult pathway up to diagnosis found it very hard because there was nobody, all these things were happening to them, they were having investigations, but there was nobody for them to go to say what's next, what's happening. And so we find it's really important that the patient has our details and our contact and can contact us at any time. We do acknowledge that we're not in the office, but we do provide an answer phone so that we will get back to people. Knowledge is key to everything. We need to be knowledgeable, we need to have an in-depth knowledge, and that's the point about having somebody who's a specialist for a very small area of expertise. It does mean that the knowledge is in-depth so that we can support properly. And the service development, which is what we were talking about, but the service development that takes place should be in response to the needs of the patient. So the outcomes of our activity. Now, although we want to be patient-centred and we do our very best to be exactly that, we don't work in isolation, we work in the health service. And so the health service is looks very carefully at the outcomes of what we do. And a phrase that's often used is, we need to prove our worth. And I have to say that sometimes clinical nurse specialists are seen as quite an expensive commodity in the NHS. Because we're experienced nurses, we aren't the lowest grade, so to speak. So we need to keep proving our worth, and from the NHS's point of view, that could be, the NHS, as you'll be aware, has to have constantly improving quality and patients experiencing high quality care, and you only have to read what's in the newspapers and listen to the news to know that that's quite high profile. So why do we help with that? Because we're managing complex and changing information as you go through your pathway, so you have more and more information given to you. We need to support patients around choices. So we've long passed the days when the doctor made the choices for you, but told you what their recommendation was, and then it's your choice. When we are there to support you with that choice, not to tell you what choice to make. Delivering care flexibly, so that for some people who live in Sheffield, the hospital's local, but for patients coming from a distance, that's much more difficult. So we can look at things like maybe the actual care, and the oncologist is in the centre, but perhaps scans can be done elsewhere. Sometimes we arrange for patients to have blood transfusions done locally, so that they're not constantly travelling. We also have some of the chemotherapies now that are given in people's own homes, in syringe drivers and things, and we then will organise and liaise with community services to take those down when they've been finished. We've also got support patient groups. From our point of view, the patient's peer group support is so important, because you're the people that really understand what each of you are going through, and that will make a difference to the experience that you have and the quality of the care that you have. Reinforce safety. Again, the NHS has to be safe, so what's our role with that? We have to ensure that what we do is safe practice, so it's knowing what our boundaries are, so it's knowing that we've got the knowledge to give you this bit of advice, but actually we have to go elsewhere to get the rest. And in a way, monitoring symptoms and drug toxicity is more for us, from our point of view, of educating and giving you the information so that you are aware of what's happening. Because what we obviously want you to do is be safe, and where we are, that means if you have a problem with the medication, it goes back to our hospital rather than to us, because we're not there 24 hours a day. And we will facilitate referrals where necessary. So we'll refer on to other agencies where to help as well. So we have to demonstrate leadership, and that's probably more to do with professionals rather than anything else. So we have a role for educating wider healthcare teams, and that where something like as rare as a gist is, our colleagues will phone us and say that this is what's happened, and they will ask for information from us or advice from us. Identifying the service improvements we've already kind of touched on really. We are responsible for doing those sorts of questionnaires, responding to the changes that need to be made, and auditing and sharing good practice. We audit our care, and we have meetings like we were at the sarcoma conference this year, and there's a nurse forum where we can share practice with each other. Now, increasing productivity and efficiency kind of makes you want to cringe a bit, doesn't it? It doesn't mean that we need to find more patients. It means that really and truthfully, what we need to do is to ensure that what we do to support you means that you have the greatest quality of life that you possibly can have. And so therefore we don't want you in hospital, which is also, I'm sorry to say, expensive to the NHS. So it's not something that, you know, we want to say this is our main role, but we have to be realistic that that's what happens within the NHS. There are more and more nurse-led services, because although we may be expensive nurses, we are cheaper than doctors. And although that may be a supportive role, it is still something that's happening. Empowering patients to self-manage, and really if I said anything about that, I'd be teaching you to do what you already do. So I think it's self-explanatory really, that the more you know about your illness yourself, the more you self-manage, the better it can be for you. And the last thing is about collecting data for peer review. All the cancer services in this were peer reviewed. There are changes coming, but there is still in essence a peer review going on, and it ensures that there's a standard across the country, and we are responsible for collecting some of the data that goes towards peer review. So that's in a way about the quality of the service and our productivity and efficiency. So some of the things that we're collecting now are that we're doing holistic needs assessments. They are that we are there when you're given a cancer diagnosis. So the summary, I would say, for this little part is to say that Sheffield's setup isn't necessarily replicated anywhere else. How we do things in Sheffield isn't necessarily how it's done in another centre. The essence of what we do is to support patients through a complex pathway, and we also have a broader remit within the NHS. So I'm going to hand over to Maxine now.
So we deal with patients from diagnosis. We see patients with one of the abdominal surgeons before they know what's wrong with them. They come with a lump in their abdomen, they don't know what's happening, no one does. So it's reassurance at that point. We have a process that we follow in obtaining tissue samples and arranging scanning, and just ensuring, you know, that they know what's happening and keeping in touch with them every step of the way, and providing a contact number as well for when they go home and they are worried about what may be wrong. In some cases it's not actually a GIST, but because of the risk that it could be, or a sarcoma, then we still give our contact details and we're still there as a port of call. We have had patients that come from different localities, and even some from our other upper GI surgeons. And I will be honest with you and still say now, we still get we've had a couple of patients who have been told that they do not have a cancer. So when they come to see Professor Wall at the trial centre, it's quite a shock, and they don't understand why they need to come to Weston Park or the trial centre. So because we've got the experience in dealing with this, it's just supporting patients through, you know, the understanding and the rationale as to why that's happened. And we do look now still at educating our colleagues. So it's just supporting them through that and working through the treatment plan for them, because obviously that's a very individual thing. We provide information packs for patients and their families. We don't force them, we're not on commission, but we do give them Just UK information in the pack. In fact, it's all Just UK stuff. So we provide that information. A lot take it and will have a look and ring us up, or when they next come to clinic will ask us questions. Some patients don't look at it, but the families will, and the patient will put it in a drawer, and that's fine, because we say when you're ready to look at it, then please, you know, do. And if you have any worries or queries, telephone us. We can meet up with you separately from your appointments, or drop us an email, whatever you're comfortable with. An increasing thing is the fact that GPs don't know a lot about GIST. So what we do is we can provide patients with an extra leaflet to take home and take into the GP surgeries, and some of the GPs have actually displayed them as well up on the wall in the surgery, so that's been quite helpful. But it does raise awareness. So that's something that's offered. We give a written record of information to patients, and that's what that is the first consultation when you go in and you're told everything about what's going to happen, basically. Sometimes we have to be the advocate and say, maybe this person's had enough for today and we need to give another appointment. Sometimes we say we need to stop the consultation now, let's have a break and then go back. It's wherever the patient's comfortable with. But sometimes it's patients sit there and, you know, they don't feel comfortable in saying it's too much, but you can tell with the look on the face, and they just seem to have switched off, which is quite understandable. And you have to step in and say, can I just say, and take it from there. And I think that's quite important. But what we do is we offer either a copy of the letter that the consultant does, or we will write a synopsis and give it for patients to take away with them. They often find that quite helpful. And then, as Gill said earlier, we do always give a contact card, if nothing else, and that has a bleep numbers on, telephone numbers with answer machine if we're not in the office, and emails as well, so it's whichever method they would like to get hold of us. Right, treatment explanation. I know Professor Wall and other people have talked about mutation analysis and that sort of thing, but the reason I've put that in and the medication is because it's quite difficult when you're dealing with patients who will say, yes, you have a GIST, yes, we've done further tests, normally this is the treatment we would give. Unfortunately, in your case, that's not possible because you have the wild type, so that can be quite difficult for patients to accept and take some working through. So that's why I've put that section in there. Starting medication can be quite scary for patients, obviously. All the side effects are gone through and it's really worrying. Obviously, if we're giving it preoperatively to try and shrink any tumours to make them operable, then that's taken on board. I don't know, patients are more pliable and will, yes, I'm all for it, that will help if it will make it operable. But also if we're giving it after the surgery, that can be difficult for patients, because some patients, they will need it indefinitely until it stops working and we move to another line of treatment. Some patients, they have the treatment for 3 years afterwards, and when they start getting the side effects, they find it really difficult to deal with, and they want to know, why am I really doing this at all? So it's really difficult, and it's just supporting these patients and talking through things. And just, you have to listen to what patients want, and if they don't want to have the treatment because the side effects are so bad, then we accept that and we acknowledge their fears, and if it is a big thing and they say no, then we stop. But if we can work through things with them, then we do. We have got a number of young patients coming through, and we've had one young lady has been to the pause clinic, found it very, very useful. Another young lady is willing to go, and we've got a young lad as well that we're also going to discuss this with when we see him next time. So that is a really good thing. But we also have the teenage and young adults. It's an MDT, and that's full of, like your normal sarcoma MDT, but it's full of the psychologists. Teenagers and young adults get a very good service. They have psychology input, they have support worker input, specialist nurse input, and there's so much out there for them. So we always talk about patients at this meeting, and then when we see the patients, we offer them this service and say, if you are interested, they will be in touch. Then we go back to the MDT, we tell them what the treatment management plan will be, and then say they would like your input and they make contact. Okay, and that gives them access to a lot of services. Right, talking about the side effects. One of the other problems with side effects, some patients will take medicines despite, no matter what the side effects are, they want to keep taking them because it's working. And so some of the difficulties are, we don't want your foot to fall off, but you need to stop and have a rest from treatment. So that's just demonstrating that some patients will put up with a hell of a lot if they think they're getting a treatment that's going to help them. So it's just helping them to understand that yes, you may get some side effects, they may actually get worse, let's manage them. If we can't, you need a bit of a break from treatment, you need a reduction in your dose and that sort of thing. So it's just explaining all that. So that is an extreme for anybody on treatment. I've not seen any of that myself, but just to highlight it. We attend clinics across the board, as Gill said. It's nice to keep tabs on people. We see patients that are not having any treatment at all, they're just under surveillance. We see patients that are having treatment. We see patients that are stopping treatment or switching treatments. It's good to be involved throughout the process, and that's something you establish a rapport. You get to know your patients, you know what they like and how they react to things, and sometimes it just helps to tailor an approach when you have to discuss the fact that they actually need to start treatment or stop and things like that. We have a healthcare professional clinic now, and that's running patients that are on imatinib and Sultant. It's a pharmacist that does the assessment, but we go in as well. It's a bit of a double act. So Becky will talk about the side effects from the treatments and suggest various things and prescribe things. But it's quite good to be in there because if there are other things that patients are struggling with and they need extra support or just want to bounce things off you, then it's very good for us, because what we can do is say, well, why don't you pop round to the Cancer Support Centre? It's just a drop-in centre. Go in, have a cuppa, have a biscuit and just have a chat to the ladies. And they find it very useful to go and see someone outside the arena as such who doesn't know them, and they can say exactly what they think. An important time is scan results back. You've got a right trigger finger. An important time to be there is scan results. Because obviously it's a nerve-wracking time. Even if patients aren't on treatment and on surveillance scans, we understand it's a very, very worrying time for them. The fear that they're going to walk in after having the scan and waiting 2 weeks to come and see us for the results. We understand it's a very trying and troubling time. So that's why we like to go in with patients then. The other thing is, I'm giving a top secret away here, Barry, that if you don't go in and then a scan does show something, then when you do go in, it's a massive alarm bell for patients. So I think that consistency of you being there through surveillance, and then possibly if anything arises, okay, but if not, okay as well. So it's just that consistency and being that person that's a natural link for them. And I've said about the treatment change. The other thing is, we always say to patients, if you have any worries or concerns before your appointment time, ring us and we will change your appointment. Sometimes it's a chat on the telephone, and we just talk through what's happening, and it could be just something that needs to be seen by the GP. Other times it's right, I've made you an appointment for next Tuesday. And sometimes if it's an emergency, you say, no, I'm going to hang up now, ring 999. Thank you, Jen. Right, so I've talked about end of treatment. For patients who've had adjuvant treatment, they're usually well actually, once they've finished the treatment and they just come back for surveillance, those patients are usually quite happy. They come back to the joint follow-up clinic and have interval scans, and usually no issues, but we are there if they need us. And the other end of the spectrum is when treatments are no longer effective. It's working through the lines of treatment. It's having realistic expectations as well about what treatment can do. And it's keeping it real sometimes, but still providing the hope, as was said earlier, but it's just being realistic about things. When treatments stop working, we are still there for patients, and we will say, if you need to come in and talk to us separately, we can see you somewhere on the ward or something like that and have an hour just listen to your fears and concerns, but then we also have to start bringing in community services, because a lot of patients, if treatments have stopped working, don't want to be dragged back to the hospital, you know, for visits that may be unproductive. If they're not feeling very well, it may actually drain their energy. I mean, they can't actually do what they want to do with the energy they've got, and it's all about quality of life. So sometimes it's an open, give us a ring and we'll bring you back in if needs be, but we will raise the issue of getting community services in so they can build up that rapport that we have as well. And we're a good link with the community teams as well. Right, so in the future, a big thing is the survivorship agenda. Looking at Barry Yates, he prefers survivor. So it's dealing with a lot of the thing now. Macmillan are doing a lot of work linking patients that have down the line in the treatments, and at the minute they're working with colorectal and breast cancer patients, and they're just starting to work with lung cancer patients. And it's actually patients that are doing well and have had the treatments, instead of them being brought to hospital for their follow-up, they are being seen at their GP surgery. So the GPs have protocols which tell them which tumour markers to do, what tests they need to do and that sort of thing. And that is the way that a lot of the services are going, they're being taken and given back out to the community. Now, we're not saying this is definitely going to happen for sarcoma or GIST patients, but it's just something that we feel we ought to raise because, you know, it is out there. The plans for that is that the nurse specialist would be a link between the hospital and community, and there would be a fast track service back in if the GP surgery was worried at any time. So they would not be waiting if people have had a long protracted journey through to getting to the correct people and the oncologist and that sort of thing. It would not be the same because the link would be direct with the nurse specialist to get people back in. So we have to work with that. We keep getting asked to do nurse-led clinics. As Gill said earlier about the cost effectiveness, we already do a nurse-led clinic for the thyroid cancer patients, and that works very well, and we've audited that and it's been very well received. But it is something that we will be looking at quite shortly, bringing it in for the GIST and sarcoma patients. We're working on a handheld diary so that patients can have some ownership of their disease and their treatment and management. So in that there will be things like, this is your team and name the team, pictures of the body and, you know, pointing out where in the body you had your surgery, what was removed, what surgery was done. Support group information will be in there. But there will also be things like the holistic needs assessment, and that is something that's quite important because it addresses things, not just psychological, physical things, but it's financial and it's looking at the whole picture. And sometimes it's things that patients don't want to bring up or feel embarrassed to bring up. So that's what we're trying to capture with that, and we're going to incorporate that into the handheld diaries. And what that does is it means that patients can flag up what their worries are, and then we signpost or help and support again. We have, to our support group last time, we showed them a number of holistic needs assessment. Wording's very strong. We used to use something called a distress thermometer and wondered why we never got any back. Well, patients would say, I'm not really distressed. So we had changed it to concerns thermometer, and we did start getting some back. But following work with the support group, which threw some back across the table very quickly, we are making our own, and it will be put back to the group and make sure they're happy before we start giving it out to patients. So we work together, a bit of a tag team, and we take on board. We've got a very good support group, very well attended, and the GIST patients are very prominent in the running of the group. And also data collection, as Gill said, it's proving our worth, unfortunately. And we have to do patient experience surveys, write reports, and our input and the number of patients we see and what the outcomes are from our interventions are all measured. So we have to provide that information. So, yeah. And at the end of the day, all we want is to help patients as much as we can, try and work together as a team. We work very closely with Professor Wall, Dr. Robinson, and I think we've got a good team, and with the patients, to try and provide a good service, but we're not infallible. One of the things when we were getting this talk ready today, we see patients as nurse specialists that are moderate, intermediate, high-risk GIST. The low-risk GIST stay with the localities or over with the surgeons at the Northern General. We have very good links with the upper GI nurses at the Northern General. But what we have found out from doing this little bit of a talk is that the information that those patients get is lacking. So I've discussed things with the upper GI nurse at the Northern General yesterday, provided her with GIST UK information booklets, which have been directed through to before, but she denied all knowledge yesterday. So I've left her one this morning on a reception. She's going to pick that up, and I will either have to contact the localities and say, can we give you GIST support leaflets to give out, and do a full pack so that they're getting all the monthly support centres in Sheffield and that sort of thing, plus the GIST national stuff. Or I'm going to have to do an audit and send out a questionnaire, nothing simple. Send out a questionnaire and say, would you be willing to accept this? But that is the way forward. You think you're doing a good job, but when you look round, you think, oh, maybe not as good and we could do a bit better. So always aim higher. Thank you for listening.